who's joined our group from Children's Nebraska. That's Chris Curzon. And then Alan Newen is our SCAI liaison who's helping us coordinate this. We have a packed hour for coding information, and Mark's going to start off with going over the 2024 codes, and then also some of the new efforts that will happen in 2025. And that followed by 6 different questions or topics that we've gathered from over the year from different people who've submitted these questions. And so the topics are going to be sort of trying to answer some of these important questions. Sean's going to talk about normal versus abnormal connections. Chris is going to talk about cardiac transplant catheterizations, congenital versus non-congenital. Guru Hiramath was focused on intracardiac stents, hybrid single ventricle interventions, followed by Jeremy Ringwell, who's going to speak a little bit about the transcatheter PDA stenting and then PA stenting. Nicole will go over the coarctation stents, particularly when it crosses side branching, because that can be confusing. And I'll end it with going over some of the modifiers of codes that are useful. Okay. Now, just bear in mind, everybody, that congenital heart disease coding is not a perfect science, and there are many gray areas. Sometimes we ourselves don't always agree. But there will always be one case in which the descriptions, no interventions, there's just no good description for that unique intervention. But as a work group, we've done our best to adjudicate the questions, and we will be discussing those today. Slides do represent the agreement with the group, even though there may be some exceptions to the rule. Feel free to send emails with specific questions. So without any more delay, we're going to take these questions, and even if we don't have time to answer them today, we'll get back to you guys. So without any more delay, Mark, why don't you take us off with your presentation?
Thank you, Dr. Ng. I appreciate that. And just to quickly reiterate, I think, as presenters of this particular webinar, we may be considered experts, although I might put that in quotation marks in the sense that we have spent a lot of time and energy discussing these things amongst ourselves, trying to make sure that there's some uniformity and agreement. But in fact, we know that there's some gray zones to that. And so we're presenting tonight, all of us are presenting what we think are best practices for CPT coding. And I'm going to lead us off here with the new venography codes, and we're almost half the way through the year. But these were the new 2024 CPT codebook codes for the venography code set. And the first code was the 93584 that was added. This was for an additional SVC, or a contralateral SVC, for the first or only SVC that somebody has, which may be the case for situs inversus, for instance, one would code the SVC code that is already existent, 75827. If there's any time a second SVC that's then also injected, then we code this new code 93584. Here are some examples that I'm showing you of a right-sided SVC on the left side of the panel going to right atrium. That would be a normal one. And then on the other side, in this same particular patient, you can see there's a small bridging innominate vein at the top there, which is really not terribly important, as this is really the big carrier flow from the left side of the upper neck and arm. So a left SVC, in this case, draining to the coronary sinus. Here's just another example of someone who actually has a larger innominate vein, but also has a left-sided SVC and a right-sided SVC. In this case, the right SVC was injected, and unless this left one were done, that would be separate. Here's just another example of getting to it from a different location. We're going up an azygous vein, in this case, going down into the chambers of a patient with heterotaxy syndrome and up into the right SVC. But again, if that's the only one injected, we would code that as a 75827. If it was the second one, we would use this code, the new code. The second code is the 93585 for azygous and hemiazygous. And you kind of get a chance to see what these things look like. There's a variety of different things how these can look, whether they're left-sided or right-sided. Sometimes in this case, crossing over. The injection here was in an azygous. Whether you term that an azygous or a hemiazygous, it would be the same code. Here's a lateral showing that it's behind the heart as it enters into the superior vena cava from above. It's not going through the hepatic vein. And here's just another example of a hemiazygous. The third code is the 93586, the coronary sinus code. And here's somebody with a lateral cable tunnel Fontan. The injection was actually in that lateral cable tunnel. We started to see something that looked a little funny here. And then we went directly into the coronary sinus and injected that. And you can see that there was also some collateralization, but that's not as important as what we did here with the direct injection selectively into the coronary sinus. Again, these are all selective codes. And then the final two codes are for veno-venous collaterals. And again, this is not including transcatheter closure of any kind, but if one only does a selective injection. On the left-sided panel, you can see a picture that was done in the innominate vein that drains into its respective pulmonary arteries. But then there happens to be a VV collateral, veno-venous collateral vessel, that is not selectively injected, but showed up on the picture. Then the catheter was put in selectively for that picture, and the code of 93587 is warranted. Keep in mind that there's a MUE of 2. What that means is that you can use that code twice, but not more than twice. So if you had 7 collaterals that you did selectively, you only get to use it twice. That is the current. And MUE is kind of funny terminology that means medically unlikely edits. It's part of the CPT RUC nomenclature. And then finally, this is, and what I failed to say, I guess, is that these are veno-venous collaterals that happen to arise from above the heart, as opposed to 93588, where the veno-venous collaterals arise from below the heart. And here you have, and maybe this is not, maybe that is in the way here, not sure. But here you see a collateral where the catheter is actually almost below the diaphragm or at that level and injecting directly into a vessel that then courses superiorly. You can see this is a veno-venous collateral vessel and happens then drain down into a left-sided SVC. The important thing is that this was selectively in this VV collateral. So those are those, and I just wanted to kind of thank you all for your attention, and I will close it out. You're muted, Frank.
John, you'll go next, right? Perfect.
Yep. Am I unmuted, everybody? Looks like I am, yeah. So thanks everybody for joining. Sean Botley-Bala. I'll just spend a couple minutes. We thought it'd be helpful to go over the congenital base codes. As Frank mentioned, you know, even among our group, the way we approach some of these things has evolved, and we're all on the same page. But we wanted to make sure we convey that to you guys, to our community. So I have no disclosures. So just as a reminder to everybody, these are the updated base codes. They're for congenital lesions only, and they were broken down into having normal versus abnormal native connections. And then there's a right heart cath, 935, 9393, and a 594 for normal and abnormal native connections, a left heart cath only. That was a new add-on that we had. And then a right and left heart cath, and again, for normal and abnormal native connections. And so I think part of what we wanted to convey is the evolution of how we've looked at this and how we kind of think about the abnormal and native and native and non-native and normal connections. And I think for those of you that trained von Pragian, and I don't want to hopefully, you know, get people fired up about Andersonian versus von Pragian, but the von Pragian sort of approach of having alignments and connections, I think, helps here. And so the point is that somebody with normal, quote unquote, normal connections per CPT has both normal alignments and normal connections. And so that means the alignments are the vena cava connecting to the, flowing into the atria, and then the atria flowing, blood flowing into the ventricles and then out to the great arteries. Those have to be normal alignments. So IVC, SVC to the right atrium, then to the RV, then to the pulmonary artery and pulmonary veins, then to the LA, LV aorta, like we all know. There's also the connections, which is, you know, from a technical standpoint, the endocardial cushions connect the atria to the ventricles, and the conus and the semilunar valves connect the ventricles to the great arteries. If those are abnormal, we would code it as an abnormal connection also. So kind of the take home is that to have a normal connection, you have to have both normal alignments and connections, and then abnormal, either of them have to be abnormal. So for instance, here we'll talk about some of the, on the next slide. I just included this slide, by the way, for people that want to read through the specific descriptor. I don't think we need to go through the whole thing. The one point about this, though, is remember when the CPT descriptors, they're not all inclusive. They are typical. And so just because something's not specifically mentioned here, obviously does not mean that only those lesions are the ones that can be considered abnormal. So please don't get too hung up on those descriptors. But here are some examples, right? Essentially, the normal will be simple things like isolated ASDs, VSDs, PDAs, and coarcts. We were actually discussing this as our group of congenital or inherited cardiomyopathies. And, you know, we all, not to steal anyone else's thunder, but felt like that was appropriate to consider to congenital, even if phenotypically they arise later because you're born with it. You know, you're born with a genetic defect. And then potentially also idiopathic pulmonary hypertension. That may be a little bit gray as long as you consider it congenital. You know, you just need to document that you consider it a congenital pulmonary hypertension. And then that would be a congenital cath with normal connections. And, you know, to be honest, pretty much everything else is going to be abnormal. So valvar, PS, and AS, and whether it be simple valvar, you know, the 2-month-old or 6-month-old or however-month-old baby that comes in that's doing well, and a critical AS and PS, all would be abnormal. AV canals, right, because that's an abnormal connection between the atrium and the ventricles. Any cone or truncal defects, obviously, TETs, truncuses, transpositions, whether it be D or SLL, veins, Epstein's, and any surgical shunt or conduits. Obviously, any surgical shunt or conduit that's creating an abnormal connection would be considered an abnormal. And that's really it. We just, like I said, wanted to just highlight the fact that this has evolved over time, because in the past we'd had some slightly different recommendations. But again, as Frank mentioned, these are all what we've come together as a consensus for the group. And if you have any questions, you can feel free to email us. And I'm a big Panthers hockey fan.
All right. Thanks, Sean. Chris.
Sorry, I wanted to kind of go through some of the post-transplant biopsy codes, because I feel like we feel as a group that that's been an area that has some confusion with it. And I think that Sean just set kind of a good stage for that in terms of when to use the congenital, when to use the non-congenital cath codes in association with these kids post-transplant. So I have no disclosures either. So in general, you have to look at what their fundamental cardiac disease is in terms of what you're doing for it. So if their fundamental disease is that of something that's acquired, right? So your cardiomyopathies that are acquired, myocarditis, things like that, those would be non-congenital. And we'll come back to these kind of cardiomyopathies that are genetic in their etiology, but anything that's sort of this acquired disease that you're doing a cath and a biopsy for, then you're going to use the non-congenital codes for that. So in this situation, if you're just doing a right heart cath with a biopsy, right, then the 93451 is the non-congenital right heart cath, 93505, and then the 75970. The 505 is the biopsy, and then the 970 is the RSNI code that goes along always with the biopsy. So these two are always paired, and then this is the non-congenital right heart cath. Okay. If you then add in, say that it's an annual, or you're doing a left heart cath with coronary arteries, then you're going to add that in. So again, you're going to have the 93505 and the 970 for the biopsy component, and then you're going to add the 93458, which is the non-congenital left heart cath, which includes the coronary arteries with that. Okay, so then if the patient's disease is that of not an acquired, but is failed from their congenital heart disease, then what you have to sort of look at is, do they have anything what's termed as residual disease or residual issues which are related to their congenital heart disease? If there's, and we'll talk about what those residual issues might be, some examples, but if there are no residual issues, they had, congenital heart defect, they had a transplant, they have nothing left over at all, nothing at all related to their underlying defect that they were born with, then you're going to go back to the schema that we just went through with, the non-congenital codes for right heart cath biopsy, as we laid out on the previous slide. And then if you're going to add in a left heart with coronary arteries, same thing, you're going to add in that left heart cath with the non-congenital left heart cath with the biopsy codes for that. So residual issues, what does that mean? the key here is that there, in some like what both Mark and Sean have said, we can't lay out everything, and there's going to be lots of things that we all encounter crazy, strange things in these patients. And so residual would be anything that you think is realistically and believably attributed to or as a consequence of their defect. So that could be something like pulmonary arteries that you previously had to stent, that maybe have some stent left over in it that you're having to address. Similarly, from a hypoplastic left heart, if they have some leftover arch issues, they may have vena cava issues that were left over. You have a patient that during the course of their treatment and their palliative procedures, they were on ECMO. And then as a part of that, even though they tried to repair when they came off ECMO, they lost the right-sided IJ. So now you're having to come in from the left side because it's a non-standard sort of approach for that right heart cath and biopsy. Those would be some examples of things you would do that would say that you have residual disease from that. So that's what gets us into then using the congenital codes. So again, cardiomyopathies that are that of genetic origin, that does not have to be in, and Sean sort of said this too, something that is in a neonate only. If it's truly is something that is genetic, then it's something that they had at birth, even though it may not manifest till they're later in life. So, or then again, fundamental failed congenital heart disease with any residual issues. And it doesn't have to be a lot of things. It can just be any one thing there. And then you're going to switch then to the congenital cath codes. So again, your 505 and your 970 for the biopsy, and then the congenital right heart code for congenital abnormal native. And then in this situation with the congenital codes, any additional angiography that you do, you need to code those things. So if you take pictures of the pulmonary arteries because you're evaluating those, or the aortic arch or the SVC, then you need to put in those appropriate codes for that. If you're going to add in and do left heart cath and course because it's their annual, then you're going to do the 505 and the 970 for the biopsy. Add in now the congenital right left for abnormal native. And then in that situation, because you're doing the coronaries, in the congenital left heart cath, it does not include the coronary angiography. So you can add in this 93563 for coronary angiography. And then again, similarly, any other angiograms that you do during the course of the case, you should and need to code and bill those things. This is another one that's a point of discussion and debate is, fortunately, the group did a good job in setting up these codes, and the 93598 for thermal dilution, while it cannot be utilized for the non-congenital cath-based codes, it can be used with congenital codes. So all the codes that Sean just went through, if you do a thermal dilution with that as part of it, it is not bundled into the right heart cath. So in these kids that you're doing post-transplant biopsy, right heart cath, and you also do thermal dilution, you should put in the 93598 for the thermal dilution component of that. So again, anything that's residual, what's key here is that you provide wording and documentation that supports that. Something that tells and talks about why you're doing what you're doing. It will help to support that from your coders and biller standpoint, and it'll just help to make it so that it's less questionable. So there's no like template to use, but just these kinds of phrases or wordings in terms of things that you're doing to try to explain your reasoning and your thought process for it. And that's it. So hopefully that helps a little bit.
Thanks, Chris. Guru, you're up.
Hi, everybody. I hope everybody can hear me. I would like to thank everybody for giving me the opportunity to present today. The topics that I'm going to be covering today are a couple. I will be focusing mostly on the intracardiac stent codes, and I'm going to spend just a couple of slides on hybrid single ventricle procedure here, and that will create a segue for our PA stent codes, and that Jeremy is going to be presenting. I do not have any relevant disclosures. So the intracardiac stent codes, this working group, we worked quite successfully to create some new intracardiac stent codes that were introduced in 2021, and including in addition to the balloon atrial septostomy codes, and this is going to be just a refresher of the intracardiac stent code portion of those new codes. That includes the 33745, which is the transcatheter intracardiac shunt creation, the first shunt, 33746, which is the additional stent code. Here's the long descriptor for that. We don't need to go over the entire thing, but a couple of highlighted points here. The 33745 code is for intracardiac stent placement for congenital cardiac anomalies. And the reason I highlighted congenital cardiac anomalies is that it cannot be used, for example, if you stent the atrial septum in somebody on ECMO who's non-congenital. I highlighted some examples that are here for the long descriptor. This will include the atrial septal stent, the Fontan fenestration stents, the RVOT stents that I will show some example about, the mustard sending Warden baffles. They all come into intracardiac stent codes. And the way we thought about it when we created these codes were, if you place a stent somewhere and if you have to move or displace, if it falls into the heart, whether it's the upper chamber or the lower chamber, that means it is an intracardiac stent code. That's how we thought about this when the codes were created. So this does include a diagnostic right and left heart catheterization. It does include stent delivery and any additional stent placed at the same location. Say, for example, sometimes we'll have to extend a stent with a stent in a stent. It does include angioplasty at the same site. So, for example, we pre-dilated the area before placing a stent. But what it does not include is angiography. Angiography, and we will come to that in the next few slides, is always additionally reportable as long as it is not road mapping angiography, but angiography for diagnostic purposes. And angioplasty or any other intervention in a separate, distinct lesion can also be reported separately. And what I highlighted here again is, some of these patients may be less than 4 kilograms, and Dr. Ng is going to talk about modifiers, but a modifier 63 can be added to these intracardiac stent codes. I'm putting in parentheses that unlike the balloon atrial septostomy codes where the modifier is already included, for these codes, a modifier 63 is reportable. In that example of the descriptors of what are considered typical examples of intracardiac stent codes, the one example that was not written there is pulmonary vein stent. But pulmonary vein stents are intracardiac stents which extend into the left atrium. So I just wanted to highlight that that is also a very common procedure that is done in a congenital lab, which is an example indeed of an intracardiac stent. 33746 is the exact same thing, but for the additional stent. It has to be in a distinct second location. As I mentioned, cannot be a second stent in the same location. Just wanted to highlight that point. With that, let's go over a few examples. I have 4 or 5 examples here of typical intracardiac stents that we use in congenital heart disease. Here is an example of an infant who's got 2 stents in the left upper pulmonary vein and the left lower pulmonary vein. So the way we would code that is we would do 33745, which, as I mentioned, is the initial stent code. It does include diagnostic portion, ultrasound guided access, and any angioplasty you may have performed at the same time. We could, in addition, report 93574, which is pulmonary vein angiography, because diagnostic pulmonary vein angiography is not included in the initial stent code. And for the second stent that was placed in the left upper pulmonary vein, that would be a distinct second location. So that would be 33746. So this is a good example of intracardiac stent code for pulmonary veins. Moving on to intracardiac stent code for atrial septal stent. This is an example of a newborn baby who we stented the atrial septum in the first few hours of life. We created a communication between the right atrium shown here and the left atrium with the transseptal puncture. We dilated the atrial septum with a balloon followed by stent placement. Here we could grab all aspects of this procedure with just one code, 33745. Includes both the diagnostic right and left heart cath, ultrasound guided access, as well as angioplasty at the same location. The third example I have is an example of RV2PA conduit stent, or the, also known as a SANO, proximal SANO shunt. In this example, we have a catheter going through the right heart into the right ventricle and a wire through the RV2PA conduit. And as you can see here, there are 2 stents we have placed in the proximal RVOT conduit. One to extend the stent further into the right ventricle, And here again, we can use the intracardiac stent code 33745. Even though we placed two stents, it was in the same location, intended to extend the same stent, and therefore we cannot code an additional stent. 33745 would cover for that, but we can code for angiography, so that we can code 93566 for RV angiogram. I want to contrast this. If we had done a distal RV2PA conduit stent code, that would not classify as intracardiac stent code, and that would fall into the group of pulmonary artery stent code, because if that stent were to move, that would go into the PA, and Dr. Ingwald is going to talk about PA stents. The last example I have for intracardiac stent code is mustard baffle stenting. Mustards are a type of surgical procedure for transposition of great arteries where the SVC and IVC are baffled and connected to the left-sided ventricle. And in those patients, sometimes like in this example, they developed narrowings, which needed balloon angioplasty and stent placement. In this particular patient, we did angiograms of the SVC and the IVC to diagnose the stenosis. We angioplasted the superior limb and then followed that up with stent placement with the superior and the inferior limb of the mustard baffle. So the SVC portion and the IVC portion. And this it would be billed with 33745 again for intracardiac stent placement, which would include the diagnostic cath and angioplasty as well. But it does not include angiography, so we can use 75827 for the SVC, 75825 for the IVC, and we add the second additional stent with 33746. I hope that is clear. I wanted to emphasize what Chris just mentioned, that accurate and proper documentation is extremely critical, and it really sets the way for billing our billers and coders to and makes their life easier for doing and helping us with all the right codes. And the example for how you can probably bill for a SVC diagnostic angiogram, which is separate from road mapping angiogram, would be to use examples like this, like patient was referred for further diagnostic cardiac catheterization to determine if intervention was needed. The cranial end of SVC was normal, therefore there was and there were no decompressing veins, and just a few examples. Roadmap angiography, however, is included. So all those other angiograms that we do for a proper stent positioning is included part of the intervention, but the initial angiogram to diagnose the narrowing could be billed separately. In the last couple of slides, I want to touch one common procedure that we've been doing more often in the cath lab these days, which is the percutaneous stage 1 procedure for single ventricle. This often involves a newborn baby with a single ventricle physiology who gets a completely transcatheter percutaneous intervention, which includes a ductal stent, a stent in the PDA to provide systemic blood flow. We often place fenestrated occluders or branch PA plugs in branch PAs to regulate pulmonary blood flow, and sometimes we have to do atrial septal stent as shown in this example child. And the way to code for this is you can always code for a diagnostic cath if we did one. So that would be 93597 abnormal connections. The stent in the ductus, and Jeremy is going to go over this, is going to be 33902. That is, PDA stents will be coded as PA stents with, in the setting of unilateral abnormal connection. But for the branch PA vascular plugs that we place, we would like to call them as basically plugging or arterial embolization of the arterial field. So that will be done with 37242, which is arterial embolization code, and we'll code that twice, one for the right surgical field and one for the left surgical field. And again, in situations like this, using terms like fenestrated occluders were placed in the right and left pulmonary arteries to restrict pulmonary blood flow is probably helps the coders rather than using terms like flow restrictors. If you did a atrial septal stent, of course, we can use a transcatheter intracardiac stent code, and of course, you can add a modifier if the patient is less than 4 kgs. In contrast, if we did a hybrid stage 1, where the surgeon opens the chest for you in the cath lab and puts surgical PA bands and gives you access to the main pulmonary artery through which we sometimes place the ductal stent, then we bill two separate ways. The surgeon himself reports a 33620, which is application of right and left pulmonary artery bands, with a modifier 62 for a co-surgeon, which Dr. Ying is going to talk more about. And we, as an interventional cardiologist, is going to bill 33621, which is the insertion of a catheter for stent placement through a hybrid approach. But we add a modifier 62 for a co-surgeon, and we bill 33902 for the PDA stent. And we can obviously add any angiography and any other procedures that can be done at the same time. I hope that helps and that clarifies some of the things that we did. And we'll be open for questions later. Thank you.
Thanks, Guru. Jeremy, you're on.
All righty, here we go. Let's go to display. Here we go. All right. Thank you very much, everybody. A couple of disclosures, but none have to do anything to do with this talk. The pulmonary stent codes, which we got last year, are 33900, which is a PA stent code, normal native connection in one side. 902 is normal native connection and bilateral. 01 is bilateral. 33902 is PA stent, abnormal native connection, with abnormal defined as stent placement within the pulmonary arteries, PDA within a surgical shunt, or a post-surgical connection of some sort. And then 33903 is same abnormal connection, but bilateral. 33904 is percutaneous PA vascularization by stent, normal or abnormal, but additional vessel in addition to the initial lesions. So separate from the initial. So that should be in addition to one of the other 33900 codes. So what is included, what's not? So what's included in the code is access, catheter and wire manipulation, angiography to guide the procedure, any related angioplasty. So if you wanted to dilate the lesion pre or post stent placement, additional stent to the same lesion. So if you wanted to put a second, and obviously post-dilation and post-dilation angiograms. What is not included is the angiogram prior to intervention, a full diagnostic study if no prior study is performed or available, or the prior study is inadequate to really guide the intervention. Angiograms unrelated to the intervention, and again, angioplasty of other lesions. It's like a lot of these things kind of bundled, and there's a couple things that aren't bundled, so you got to make sure you check all those boxes. So this is an example of a 33900. This is a patient with native branch pulmonary artery stenosis, and both the right and left pulmonary arteries you see are small on the left panel. On the right panel, we put a stent in the right pulmonary artery, so that's a 33900. If we had decided to stop in this case and not proceed, that would be the intervention code for this patient. But as you can also see, the left pulmonary artery needs help as well, and so we put a stent in both right and left pulmonary arteries. So this becomes a 33901 for this procedure. So abnormal native connections, unilateral versus bilateral. So on the panel, the first two pictures is a patient from left to right, is a patient with single ventricle anatomy following a Glenn shunt with left pulmonary artery stenosis. And the stent was placed in that left pulmonary artery, that narrowed left pulmonary artery. 33903 is a patient with tetralogy flow with AV septal defect and an RV to PA conduit. The patient has undergone surgical repair, but has bilateral branch PA stenosis and underwent simultaneous placement of stents in the right and left pulmonary arteries, making it 33903. So each additional stent can be in a patient with or without normal connections, but it's in addition again to the initially placed stent. So this is an example of a patient with transposition who's undergone an arterial switch operation, excuse me, who has a stent there in the proximal right pulmonary artery, but you see subsegmental stenosis of both the right upper lobe and the mid RPA distal, and underwent placement of stents in that right upper lobe and the mid RPA. So that's 33904, which would be billed twice in this case. So for PDA stents, remember that a PDA counts as an abnormal connection, just like a shunt. And a 33902 is how we bill for a PDA stent, a single PDA stent, or single PDA stent to a isolated pulmonary artery. This is a patient with pulmonary atresia with major aortal pulmonary collaterals to the right lung, and then a left pulmonary artery fed only by a left ductus. So that left ductus winds up being a 33902 for this intervention. This is a little more complicated stent case. So this is a baby in whom we wound up putting a stent from the ductus into the right pulmonary artery, and then went through that first stent and into the left and put in a second stent. So this winds up being a patient, again, a patient with pulmonary atresia with stents both to the right and then through the right into the left. So a 33903, so bilateral for abnormal native connections. So this is a plagiarized but wonderful diagram that Sergio Bartakian made and actually used in his presentation last year that just helps you understand the cornucopia of different combos you can have here. Just as an example, a single stent into this is a surgical shunt that goes into one of the pulmonary arteries. That counts as abnormal native connection unilateral. If the stent goes into the PA, that's B. It's also abnormal native connection unilateral. And C is the first stent plus a stent into 3 or 4, so into the other branch pulmonary artery. So that's an abnormal native connection bilateral, et cetera, et cetera. And really what we're trying to account for is the work of wire placement in the first pulmonary artery and then having to go over to the other side to do other work. But I thought this was a great diagram, and Sergio let me borrow it for today. So that's all I have. Thank you very much.
Thanks, Jeremy. Nicole, you're up.
Okay. I can't share yet.
Oh, sorry, my bad. There you go. Thanks,
There we
Nicole.
go. Okay, so. Okay, so I'm talking a little bit about coarctation codes. I have no relevant disclosures. So we're going to talk about coarctation, and the main issues come in here between crossing a major side branch and not crossing a major side branch. So the 33894 is a stent repair of coarctation, and that's ascending, transverse, or descending thoracic or abdominal aorta with a stent crossing a major side branch. I'll give you some examples, versus 95, which is the same areas of the arch, but not crossing a major side branch. And then angioplasty of native or recurrent coarctation of the aorta is the 33897. So 33894 is for crossing a major side branch. And so this picture here shows the stent completely covering the left subclavian. This is from a different case, both images supplied to me by members of the team here, because I couldn't find one of mine that showed it quite so nicely. But you can see here the balloon going through the stent into the left subclavian. So this is accounting for the extra work you have to do doing this. Now, this would be in contrast to the stent that is just below the left subclavian, or that kind of goes into the left subclavian a little bit or flares its edges into the left subclavian. Those would not count as crossing major side branches. So if you look at the codes, you have the 33894 and 95. Here's the RVUs that are associated with them. What is included in these, a stent inside a stent is not something that can be separately billed for. Pacing is bundled if done, although that is not commonly done. Aortic angiography is included. The ultrasound for vascular access is included, and all three are bundled with the diagnostic left heart cath. If you angioplasty before or after the stent placement, you cannot separately bill for the angioplasty. So if you put in a stent and then redilate it, you can't bill angioplasty afterwards. Now, it's very important, the pacing, if you use venous access only for a pacing catheter, you cannot bill for that. If you perform, however, right heart catheterization, you can use either the 9.3 or 9.4 codes that are reportable based on connections, but you must document that you did the right heart cath, obviously. And an LV angiogram is not considered part of the left heart cath for the coarctation procedure. And then, so this is one of the questions that is from a previous meeting. Does stent placement for coarc need to be completely crossed, major side branches, or partial crossing? And so for coarc, the intent at CPT was that it was supposed to cross the side branch. So lesser or amount, you can't really say. And most of the images that were presented are of a type where the vessel is completely crossed. And we as a group thought that if it's completely crossing vessels, it's quite clearly crossing. And if it's the type where it's flaring into or that would not count. If it was a type of stent that was crossing in such a way that you need to go through the cells and redilate and do work into the branch or stent the branch, that would count as crossing the branch. And then we have, this was another question that I'm answering from a prior thing, was asking about whether the 741 to 746 codes can be used for non-congenital conditions. And the answer is no, they can only be used for congenital conditions. So if these are performed for adults or for non-congenital reasons, they need to be used an unlisted code. And if it becomes something that comes up in the future, they would have to get their own application for non-congenital use of any of these codes that we use. And that was my last slide. Thank you.
All right, thanks very much. I'll end the lectures with my slides on modifiers. Let me get to that. And can you guys see this? All right, Mark Hoyer did remind me that my name underneath that silhouette is not me. That's not my shadow, and I agree. All right, so here are my disclosures. Again, I know that not everybody buy this, but this is a really important resource for all of us who are paying attention to the CPT code. I know the coders and billers have them, but many of the proceduralists don't own this, and I find this to be really helpful. So if you guys have an interest in this and it pays for itself shortly, get one. Okay, so I'm going to talk about CPT code modifier. Now, I know that many of the coders and billers are familiar with these, but I think many of the providers are less familiar. So I think it's important to at least know how these modifiers can benefit you. So basically, the modifiers are used as a way to supplement the information or adjust the care descriptions to provide the extra care that you guys have that you're rendering that service provided by the service. And it can actually improve your billing when you use it appropriately. Again, talk to your billers to get familiar with this. I'm going to start with the modifier 63. I know that Guru referred to this. This is the most common one that I've encountered, meaning that if you take care of a baby that's under 4 kilos, that modifier can add more value to your work. Basically, they're smaller, more fragile, takes more work, care, stress, etc. Adds to the complexity of the work. And in fact, it adds another 20% value to what you do. So don't forget to add that in there. Now, one of the things that I've learned is that the coders review your cath notes, but if you have the weight hidden somewhere on page 3, it's going to take them a little more time to look for it. So I usually put that on the first page, bolded, so that it's obviously what the weight is, and they can use that to add the modifier when they're adding your codes to the billers. So now the other area that is often confusing and is the concept of being a co-surgeon versus an assistant. And I'll review that a little bit. The modifier 62 is really the co-surgeon modifier. Basically, what it means is that when 2 surgeons, or in this case, 2 proceduralists, are required to perform a specific procedure, each can bill for the procedure and add a modifier 2 so that they they're doing simultaneous surgery together in a situation. Again, doesn't apply as much in the cath lab, but definitely applies in the valves. So heart transplant was one example thrown out, but the hybrid valve implants that we often do these days also can apply. So how's that paid? Basically, when you have two surgeons or a surgeon and interventionist billed together as co-surgeons, you get 125% of the reimbursement, and they're split evenly across both disciplines. So the surgeons get 62.5, you get 62.5%. And that's really helpful. Now, I think it's really important to make sure that before you join in the procedure, you clarify with the surgeon so that there's an agreement on both sides that you guys are considered co-surgeons. I've encountered earlier on where the surgeons would write me down as an assist. And obviously I didn't feel that way. So after some discussion, there was clarity and both sides agreed that these are co-surgical procedures, and that way there's less argument. So I think the expectation has to be clear up front. And then again, this is very useful in a hybrid procedure in both an OR or a cath lab. All right, now 80, 81, 82 are basically the assistant codes. And again, there's some controversy here, and I'll just go through it quickly to illustrate the controversy. So basically, if the procedure, it can only allow for those codes that allow for assistance, meaning that most of what we do in the cath lab don't really apply, but it happens to apply for valve implants. So then that's just important to know. So it depends on the code that you're using. Now, I stress this in yellow and bold because it's really important to refer to your Medicare physician fee schedule to determine if a co-surgeon or an assistant surgeon is allowed. So you've got to talk to your billers to say how this might work out to your advantage or not. Medicaid allowances actually vary from state to state. So that's why this is not black and white. We talked a little bit about it as a group, but I just want to make sure people know that this may vary depending on which state you work on. It also can depend on payers. Now, in California, we know that we'll bill modify 80 for Medicaid and 82 for the federal payers like Medicare. We also learned that Medicare will accept an 80 if that's not a training center. Again, I want to just make sure people know that these rules can vary depending on where you live, the region, and your state guidelines. 80, basically one physician assists another in performing a procedure. If the assistant surgeon assists a primary surgeon and is present for the entire operation or a substantial portion, then they count. Again, you just basically will put in your code and the biller will add in the 80 as an appended modifier. This is not typical, as I said, for congenital heart interventions, but where it applies is going to be in the valvar, hybrid valve implants. And I know that that's going to increase in number over time. 81 is really similar to 80, except this is for a short amount of time, whether you're going in to do something quickly and then leaving and you're not there for all that. But again, this is a gray area. That's why you have to talk to your surgeon how you guys want to designate this. He may view you as a surgeon because he did the stenotomy, put him on bypass, and then had to do everything else, and you're just the assistant to him. So again, I've emphasized communication with the surgeon is really important before you go into the OR or the hybrid lab. A second surgeon, again, this is minimal or part of the procedure, and you can use the 81 modifier. 82 is the gray one. It's only limited to teaching hospitals. Most of us work in teaching hospitals. And of course, it indicates that you have a qualified resident surgeon is not available. The gray area is qualified. What is qualified? On the surgical side, a qualified surgeon may be one who can hold the retractor properly and know when to suck blood when the surgeon asks for it. That doesn't apply in the cath lab because most of your fellows are not interventional cardiologists. So therefore, I usually just write the resident is either observing, and if I have another cath person there, I would call that person the assistant. And you guys decide it internally. But this is a hard one because this is in a gray area for the hybrid OR or for the hybrid valve implant. A lot of times there's a surgical resident there as well as the interventional fellow. So that's why it's not so easy to clean this up. So most of us in the past have recommended to avoid using this. But again, I want to emphasize that this is a gray area. It depends on your state, your area, your region, and your payer allowances. As I said, Medicare accepts 82, but will accept 80 in non-teaching hospitals. But many times, in the past, we've, as a group, recommended to stay away from this code. Now there's a couple of ones where 58, 59 are actually for multiple procedures, whether it could be in a stage procedure where, again, this applies for those procedures that are part of the global period. Again, not very common for us, but if you happen to do a hybrid myolytic valve, let's say, and later on you find that you need a line for a clot, and you put that line in for catheter-directed TPA, and you have to bring them back later on for repeat angiography, that might apply. Again, this is rare, but just throw it out there so people know. 59 is also used for more than 2 or more procedures that are performed during the same visit at a different site. Again, this should only be used when there are no other appropriate modifiers to describe the relationship of these 2 procedures. It should never be used to try to unbundle a code. That would be illegal, or try to bypass the NCCI edits. And you guys can work that out with your coders for that. To me, a good example is that when you take a patient to the cath lab under one anesthesia, you might do a cart cath, and then the electrophysiologist comes in to do an EP study. And that would be the same encounter. That's where this could be useful. The 24, 25 are actually EMN codes, basically applied to the interventionist who's going to see the patient. Again, these only apply for those procedures that are under the global period between 10 to 90 days. And again, it doesn't apply other than the rare hybrid procedures that we do. 24 relates to the fact that you have an unrelated evaluation and management by the same physician or another person in the same specialty group in that post-operative global period. So for example, you did a hybrid mitral implant, and then you're asked to evaluate a vascular occlusion during the global period. That you can actually still bill for that, even though you were the co-surgeon within that global period. 25 is really for patients who you see a patient and you bring the kid to the cath lab because of an urgency, again, within the global period, if the patient had a procedure that was within the global period. So here's an example where you saw a patient in the ER, you bill that ER visit, and of course the kid needs an urgent cath, and you bring him to the cath lab same day. You can bill that with this modifier. That's different from an elective procedure where you see the patient in the morning for HMP and then you bring him to cath lab later on. Doesn't apply in that situation. 78 is basically reporting an unplanned return to the operating room or a procedure by the same physician following an initial procedure or related procedure during that post-op period. Only applies for those procedures that have a global period. Again, mostly going to be hybrid related. Again, this is where I find that is useful for the hybrid procedures between you and the co-surgeon, and you are billing as the co-surgeon. This is just a graph to show the kind of payments you get based on these modifiers. So in other words, rather than getting nothing, you get something. So for these numbers, you get anywhere from 78, you get 80% of the amount, 80, 20%, we're similar to 82, you get 16% for 81, and then 62 as a co-surgeon. That's one where I find it to be very helpful. You get 62.5% of the billing. And then finally, for MUEs, Mark Hoyer talked about this a little bit, stands for medically unlikely edits. I have no idea why they use that term, but basically think of it as the unit of service you can use for any specific CPT code rendered by one provider on the same day of service to the same patient. So for example, embolization codes, this was discussed. For the veins, 37241, or the arteries, 37242, you're allowed 2 times to submit that code within that same patient. For pulmonary angioplasty, interestingly, for 92991, you allow 1, and subsequent, you actually have an MU as 7. So you can actually use that code 92998 up to 7 times within the same patient. Now, I want to just point out some disparities in MUEs for congenital heart disease. And again, this has just to let people realize that we are victims of some disparities. For example, coronary stenting allows 3 MUEs. They can stent the left coronary, right coronary, and circumflex and build it as initials 3 times. On the other hand, when we do pulmonary artery stenting, you're allowed 1 time to either do a unilateral or a bilateral under both the normal and abnormal conditions. And if you add up all the RVUs, it doesn't add up to the coronary stent codes. Again, this is just some of the things that we as interventional, congenital interventionists are facing. But again, this is why we formed this group to try to work these things out and try to improve reimbursements for our community. So with that, I'm going to end, and I'm going to stop my sharing. And we have actually a few minutes for answering questions. And I know Sean has been keeping track of some of the questions. So feel free to pull up one of the questions that have been posted, Sean.
Yeah, thanks, Frank. So got a bunch of great questions. One really interesting one, which I was not aware of, and as Frank kind of mentioned earlier, there are some gray zones, and this may be something we'll have to talk about as a panel and certainly investigate more. Apparently, one of the respondents mentioned that CPT states an anomalous coronaries PFO MVP, which is mitral valve prolapse and bicuspid aortic valve, in the absence of other congenital heart disease are coded as non-congenital. So that's really interesting. I'd never heard that before. I can tell you, my take would be if the valves, specific to the valves at least, the mitral valve prolapse and bicuspid aortic valve, if they're dysfunctional and the kid was born with them and it's causing physiologic changes that we're having to cath and look about doing, or at least consider doing an intervention or even medical therapy, my opinion is that would be a congenital lesion. It's what they're born with. And this is where the nuance of how we bill it comes into play. I would code it. I'm sorry. I would call it congenital mitral valve stenosis or regurgitation, and similarly congenital aortic valve stenosis. I'll let the other people chime in, but my impression is that is probably, those are very common things. And what the CPT doesn't want the internal medicine physicians to do is, if they're cathing somebody for coronaries and just incidentally find a normally functioning bicuspid aortic valve, which is very common, they don't want them to code that as a congenital cath. But I think if the child has physiologic changes that are causing, and I see my co-work group members nodding their heads, that's how I would review that. PFO, though, I would probably agree is not congenital, I suppose, although that doesn't really, that's more of a semantics, because if we close it, it's the same ASD closure code, PFO closure code, so that doesn't really matter. Hopefully no one's just cathing people with PFOs and not doing anything about it.
I think I think in general we agree with this, and it certainly is a gray area. I think that the Alcapa, the anomalous coronary, is, most people would have coded as an abnormal. I think it's interesting that when we first talked about normal abnormal connections, we're thinking of the, like you said, Sean, the von Pragian way of looking at the segmental parts of the heart, right? The AV connection, the VA connection. But the anomalous coronary is an abnormal connection, but it's not part of those three segments. Just like we said, like the isolated RPA off the PDA is similar, because it's talking about distal to the great vessels. And so, but again, I think that in that realm of sort of the abnormal connection, I would put that in the category abnormal. What do you guys think?
I have, do you hear me? You're muted. So do you hear me okay, everybody?
Yeah, we can hear you, Mark. Yeah.
Oh, no, I would agree with a lot of things that Sean has already mentioned, and Frank as well. And I think that the funny thing is, it's hard to account for everything, but congenital is congenital, right? If it's something you were born with and it ain't normal, that's kind of the way to think about it. That may be a little bit of black and white. I would bet you there will still be some disagreement about that, but I would also bet that if you polled 100 pediatric cardiologists who happen to follow patients in their clinic that have bicuspid aortic valves on a regular basis, albeit maybe not frequently, and who have patients with mitral valve prolapse, for instance, or who discover a patient who happens to have even anomalous right coronary artery from the pulmonary artery traveling maybe between the aorta and pulmonary artery. I think we would say, if you had 100, I would think the far majority are still, or at least 75% or so, are going to call those congenital. Maybe more than that. I could be even underestimating that, but I think that's where the rubber kind of meets the road with that, and certainly I would vote in that direction.
Chris, you're on. You have your hand up.
I was just going to add to that, that maybe one of the other pieces to the discussion is if there's pathology associated with it. And that's what Sean was getting at, right? Bicuspid aortic valve, very common. And a lot of those can be undiagnosed because there's no pathology. But if we're following somebody in our clinic, certainly if we're cathing somebody that has significant aortic stenosis associated with a bicuspid valve or insufficiency associated with it, we're ballooning a valve like that, we're treating it. There's pathology there, and that's a different story than the benign, just incidental finding sort of, or the one without any pathology. Same thing for an anomalous coronary. Perhaps, you know, when we talk about some of those that have pathology associated with it, when we're talking about doing something to it. So maybe that's just another piece to the nuance that we can add in. And if we are coding, as we are doing our notes, again, getting into one of the things that Guru said and you know, advised us all is documentation. Help your team out, help your coders out. They're your team members. So code in there, whether you want to say bicuspid aortic valve or not, fine. But say, you know, patients present to the cath lab because of severe aortic stenosis and need for balloon aortic valvuloplasty or whatever, or insufficiency leading to left heart failure, but give them some information, give them some justification to help you out. So.
Great. So, Sean, are there another question? We're at 5 o'clock, but maybe we'll give a couple extra minutes for a pressing question. If not, I can ask you one, Sean, where you talked about normal connections and dextrocardia. Can you talk a little bit about that, just to clarify?
That's the one that I was going to bring up. And again, this is a great question. I'm kind of mad at myself. I hadn't thought about this. Frank sent me a private message saying, what would you do for somebody with situs versus totalis? And, you know, it's kind of goes back to what I was saying also initially is, you know, I think we can overthink some of these things. And so, you know, yes, they may have technically normal alignments, but I mean, literally situs inversus means everything's backwards, right? It means everything's inverted in the body. So, you know, I don't think it's a stretch to say that that's an abnormal connection. Everything's mirror imaged, and cathing them. You know, another fundamental thing that I think people that would like to get is, you know, these codes are based on the work done. And so it's definitely different cathing a kiddo as SL, you know, or situs inversus. Everything's backwards, like I said, right? So we're not doing the exact same work as what you would do with somebody like a transplanted heart or a completely normal native connection. So my opinion, I would bill that as a congenital abnormal connection.
Any differing
Very good
opinion
question.
in the group? Nicole, your hands is up.
Sorry, my hand's up, but it's not about that. I actually agree with what John just said. I would do situs inversus totalis is much harder than someone who's got normal everything, and think I would also do that as abnormal connections. I wanted to clarify something from the coarc section that I didn't put in my slide, and I'll add it to the slides before they go into the cloud for people to see in the future, which is that if you do an intervention on the subclavian or one of the branches or stented, you bill separately for that intervention in the cohort case. So if you have to balloon dilate through it into the left subclavian, you can bill for left subclavian artery dilation. You just need to document that you're doing it.
Great.
I realized it wasn't clear. So.
We are at 5:03, and I know that we all want to be respectful of people's time. So we'll end it here. I know that there's a few other questions that were posted, and we'll gather that up. And this is all recorded so that people actually can go look at this later on the SCAI website. And so happy to answer questions that are posted to us. And thank you again for joining us in this webinar. All right. Thanks, everybody.